Port site and incision site tuberculosis, rare post-surgical complication. Dr. Jalal Mohsin Uddin, Associate Professor, DTCD, FCPS Pulmonology, National Institute of Diseases of Chest and Hospital NIDCH, Mohakhali, Dhaka. Learning objectives. Definition of port site tuberculosis (PST). Understanding the routes of transmission exogenous versus endogenous. Recognize clinical features and diagnostic challenges. Review current management and prevention protocols. Definition and overview. Port site tuberculosis (PST) is a form of extrapulmonary TB occurring at the site of laparoscopic trocar insertion or surgical incisions. It is often a delayed complication, presenting weeks after the initial surgery. Port site tuberculosis is a rare, generally nosocomial hospital-acquired infection that develops as a complication of laparoscopic surgery, typically when instruments are not properly sterilized. Global burden of PST. High-burden countries like Bangladesh and India face significant challenges with this type of extrapulmonary manifestations. PSTB is a very rare, often misdiagnosed, chronic, late-presenting complication of laparoscopic surgery, particularly cholecystectomy, with an incidence rate often reported as less than 0.1% to 1% in most literature. PST is rare but increasingly recognized, particularly in endemic regions where it can account for a small percentage of all size post-surgical infections. A. 2-month postoperative healing progress, with circles indicating superior and inferior scar formation. B. 3-month postoperative healing progress with visible fistula. C. 6-month postoperative healing progress showing improvement. Common examples of port site and incision tuberculosis in Bangladesh. 1. Post-laparoscopic cholecystectomy. The most frequently reported case is the development of a persistent, non-healing sinus at the epigastric port site used for gallbladder extraction 3 to 4 weeks after surgery. Epigastric port site discharge. Patients often present with discharging, indurated hardened wounds, which are frequently misdiagnosed initially as pyogenic infections. Spillage of infected bile or stones during extraction can seed the port site, especially the epigastric or umbilical ports may lead to port site infection. 2. Post-caesarean section incision TB. Cases have been documented in gynecological departments where the surgical incision for a lower segment caesarean section LSCS fails to heal, leading to chronic serosanguinous watery bloody discharge and later diagnosis as tubercular wound infection. The caesarean section wound infected with Mycobacterium. Arrow equals wound erythema, arrowhead equals wound dehiscence and drainage site, star equals painful cutaneous nodule. 3. Diagnostic laparoscopy sites. Port site TB has occurred following laparoscopy for investigation of abdominal pain, suspected abdominal tuberculosis or primary infertility. Diagnostic laparoscopy. 4. Chronic sinus in post-appendectomy. While less common than cholecystectomy, chronic persistent discharging sinuses at appendectomy incision sites have also been identified. Fistulous opening over the scar of a previous appendicectomy. Pathogenesis and transmission. Routes of infection. Exogenous, direct inoculation from contaminated instruments or environment. Endogenous, seeding from an undiagnosed primary focus or reactivation of latent TB during surgery. Role of incomplete sterilization. Reliance on 2% glutaraldehyde GTA for 20 minutes often achieves only disinfection, not full sterilization. Resistance of certain mycobacteria to chemical disinfectants. Side X-ray used for laparoscopic instrument sterilization. Environmental reservoirs. Contaminated tap water used for rinsing reusable instruments is a major source of mycobacteria. Presence of biofilms in instrument sleeves and trays. Atypical mycobacteria other than Mycobacterium tuberculosis are mainly abundant in environment. Risk factors for port site or incision site tuberculosis. Sterilization failures. Inadequate sterilization of laparoscopic instruments, particularly in high prevalence areas, is a primary cause. Contaminated surgical environments. Immunosuppression. HIV infection, prolonged use of systemic steroids or use of other immunosuppressive drugs, CKD, diabetes mellitus, and malnutrition. Living in high prevalence TB regions. Pre-existing latent tuberculosis. Clinical presentation. Typical timeline. Initial surgery recovery is often uneventful. Symptoms usually appear 3 to 4 weeks up to 3 months after surgery. Or port site tuberculosis presents as a non-healing infection. Some studies show a mean time to presentation of approximately 38 to 40 days, roughly 5 to 6 weeks post-operation, with a range of 28 to 65 days. Local signs and symptoms. Persistent discharging sinus at the port site. Non-healing wounds with undermined margins. Tender nodules or cold abscesses. It often mimics a standard, non-responsive infection, presenting with induration hardening of the skin. Constitutional symptoms. Often absent no fever, no weight loss, which makes diagnosis difficult. Systemic illness is noted in less than 10% of cases. Because it is a localized, implant-type infection rather than a systemic, active tubercular disease. In maximum cases, there is no evidence of visceral tuberculosis such as pulmonary or abdominal TB elsewhere in the body, meaning the body's systemic immune response is not triggered. The lack of systemic symptoms often leads to a delay in diagnosis. Stages of infection. Nodule formation. Around 3 to 4 weeks after surgery, a tender nodule appears, usually at the umbilical or epigastric port site. Cold abscess formation. The nodule increases in size and becomes inflamed and often develops into an abscess. Spontaneous rupture. Pus discharge. The overlying skin becomes necrotic, and the abscess breaks down to discharge purulent material, often resulting in reduced pain. For persistent serous sinus, the lesion persists as a chronic, non-healing sinus tract discharging white or serous fluid. 5. Advanced infection. The surrounding skin becomes hyperpigmented, and multiple new nodules may appear at the same or different port sites. Diagnostic approach. High index of clinical suspicion. The infection often presents as a persistent, painful, red, or fistulous area that does not heal with standard antibiotics. Often provides the first clue. Diagnosis relies on a combination of clinical assessment, microbiology, and imaging, with biopsy being the gold standard for chronic or non-healing. Microbiology. Acid-fast bacilli AFB smear from biopsy material or discharging white or serous fluid from sinus tract, quick but low sensitivity. Culture Lowenstein-Jensen or MGIT, the gold standard but takes weeks. Macroscopic morphology of MTBC described as a granular left or cotton wool-like right and as B film-like without swirling the tube. Molecular methods. Gene expert MTB-RIV rapidly detects M. tuberculosis and rifampicin resistance. Expert MTB-XDR can detect drug sensitivity for second-line anti-TB drug. PCR for rapid identification. Histopathology. Biopsy of the sinus tract or abscess wall. Key findings: chronic granulomatous inflammation, Langhans giant cells, and casating necrosis. Initial imaging investigations in PSTB. Abdominal ultrasound can show localized collections or tract extension. Chest X-ray to rule out a primary pulmonary focus. Complex underlying port site sinus tract. Ultrasonography USG is a primary, non-invasive imaging tool used to evaluate suspected port site tuberculosis (PSTB). Complex underlying port site sinus tract. Key ultrasonographic findings. Localized collections. USG frequently identifies multiple collections or abscesses at the port site. These may present as hypochoy sinus tracts, located in the subcutaneous fat and abdominal wall. Fluid accumulations may appear as simple anechoic or complex hypochoy with debris septa collections. Tissue involvement. It helps determine the depth of the pathology, such as whether a sinus tract extends toward the peritoneal cavity or remains superficial. Lymphadenopathy. In some cases, USG can detect associated enlarged lymph nodes, which may show annular or separation enhancement in multimodal assessments. Role of USG in clinical management. Initial screening, used to differentiate PSTB from typical bacterial surgical site infections (SSI). Guidance for biopsy. USG provides precise guidance for fine needle aspiration cytology (FNAC) or biopsy, which are the preferred methods for identifying characteristic granulomatous inflammation. Monitoring treatment. Serial USG is used to track the resolution of lesions and assess the patient's response to anti-tuberculosis therapy (ATT). Comparison of USG with other imaging modalities. Computed tomography CT and MRI, reserved for cases of diagnostic ambiguity or to confirm if sinus tracts communicate with internal organs. Surgical planning. By providing detailed anatomical information, MRI helps in planning extensive surgical debridement and thorough dissection of the entire sinus tract. CECT abdomen show loculated anterior. Abdominal wall collection with extension till. Peritoneum. Diagnostic flowchart. Persistent port site infection site. Failure to heal with standard antibiotics. Biopsy from ulcerated site and AFB stain, gene expert and AFB-CS port site or incision site tuberculosis. Anti-tubercular therapy ATT. Standard regimen, 2 months of HRZE followed by 4 months of HR2 HRZE 4 HR. Extended treatment 9 to 12 months may be necessary for some surgical site infections in case of persistence of discharging sinus. Delayed healing or persistence of gene expert positive with RIF sensitive may warrant introduction of retreatment regimen 6 HREZLFX. Surgical management. Incision and drainage of abscesses. Wide excision of the sinus tract and unhealthy granulation tissue. It is a surgical procedure used to treat chronic, non-healing cold abscesses or sinus tracts associated with tuberculosis that do not respond to anti-tubercular therapy ATT alone. The primary goal of excision is to remove devitalized, infected tissue debridement, which eliminates dead space, reduces the mycobacterial load, and promotes healing. This surgery is not a standalone treatment, it is an adjunct to standard, multi-drug anti-tubercular chemotherapy. Prevention strategies. Use of disposable instruments where feasible. Proper sterilization protocols, autoclaving or ethylene oxide instead of just chemical disinfection. Improving surgical technique, example, use of endobags for specimen extraction to prevent port site contamination. Strict adherence to instrument reprocessing guidelines. The differential diagnosis for a chronic, non-healing port site sinus or nodule. 1. Non-tuberculous mycobacteria (NTM). This is the most crucial differential, particularly Mycobacterium fortuitum, M. kelloni, and M. abscessus are resistant to standard ATT and require drugs like clarithromycin or amikacin and often surgical debridement. Typically appearing weeks after surgery due to environmental contamination of instruments, These infections require specialized culture. 2. Chronic bacterial infections. Pyogenic infections. Methicillin-resistant Staphylococcus aureus MRSA can present as a chronic, non-healing wound, especially if there is a retained foreign body, e.g. suture material. Pseudomonas aeruginosa, another common cause of persistent, greenish, foul-smelling discharge. Actinomycosis, a chronic, indolent infection that can cause sinus tracts, although less common at laparoscopy sites. 3. Fungal infections. Rare, but can cause chronic granulomatous nodules. Frequently caused by Candida or Aspergillus species, particularly in immunocompromised patients or those with prolonged antibiotic use. 4. Non-infectious conditions. Mimics. Foreign body reaction. Suture granuloma, a chronic, sterile inflammatory response to synthetic suture material, presenting as a firm, tender nodule, often at the site of deep facial closure. 4. Non-infectious conditions. Mimics. Endometriosis. Endometrioma occurs at the port site, usually the umbilical port, 3 to 12 months after laparoscopy. It presents with cyclical pain and swelling bleeding corresponding to the menstrual cycle. Port site metastasis, a very rare, high mortality, but important differential, often appearing months after surgery for occult or known abdominal malignancies. Conclusion. PST is a rare but debilitating complication. Early biopsy and a high index of suspicion are key to preventing prolonged morbidity. Inadequate sterilization of laparoscopic instruments, particularly in high prevalence areas, is a primary cause. Ultrasonography USG is a primary, non-invasive imaging tool used for screening, evaluation and follow-up of suspected port site tuberculosis (PSTB). Thank you all. Port site and incision site tuberculosis, rare post-surgical complication. Learning pulmonology.